Hey everybody, welcome to the Med List. So glad to have you here with us today. Donna, I hope you had a beautiful Mother's Day.
I did. It was wonderful. Saw
Good.
both my kids various times, not together, but that's okay. Special
Hey,
time with each one. It's perfect.
it's so nice to be able to be together with family. I had my mom over on Saturday. Savannah and I got to spend some time together, and the boys, we tried the best to spoil her. It's never enough, but we had a really good day. So that was really special. I think the interesting thing with Mother's Day and kind of how it reflects is with moms, good moms, which there are a lot of wonderful moms out there. They want the best for their kids, right? In every kind of aspect of life. And they want to be able to deliver those things to them. And sometimes they hope they can just literally feed them. That's one part of being a mom is they're cooking for their kids and they're preparing things for their children and getting them set to be able to be successful. But then kids take off, right? They start their own lives. They start making their own decisions. And sometimes those decisions are ones that maybe they regret later, maybe learn some lessons from overall along the way. And one thing that doesn't get talked about enough, I think, in our society, Donna, is that some of those decisions can lead to things like addiction in lots of different ways, shapes, and forms. And there's sometimes a lot of moms out there that wish they could have done something differently. They wish they had some answers on what they can do kind of moving forward. And so I'm
Mhm.
really excited to talk to our guest here coming up on that exact same topic. Any thoughts there, Donna? Any mom advice, when it comes to the things that you've gone through?
Yeah, so what I think is important to know is that it happens. Addiction does happen. It doesn't always mean that someone is to blame. It is an illness that can be tended to and taken care of, and it's the conversations that are necessary. So I think we have to get rid of the blame and the shame and actually treat. And I'm so excited to hear from our guest in regards to this. So I'd love to introduce our guest. We have Dr. Jason Giles. He's a board certified addiction medicine internist with over 27 years of experience in the medical field. He's a former anesthesiologist. Dr. Giles brings a unique perspective to addiction recovery. Having personally battled and overcome substance abuse, his journey gives him a deep understanding of the complexities of addiction and the process of healing. As the founder of VHAB, an app designed to help people change their habits, and creator of the YouTube channel Jason Giles MD, he shares valuable insights on addiction, recovery, and habit transformation. Dr. Giles is also affiliated with Providence St. John's Health Center, where he works with a diverse range of patients, from doctors and CEOs to rock stars and homemakers, helping them break free from destructive patterns. So, driven by a mission to make addiction recovery accessible to everyone, Dr. Giles emphasizes the importance of honesty, community support, and understanding the psychology behind habits. Known for no nonsense approach and compassionate, results driven guidance, he empowers individuals to take control of their lives, master emotional triggers, and build healthier, more fulfilling futures. So, welcome, Dr. Jason Giles, and thank you so much for being with us. And right before we started recording, you were talking about how amazing recovery can be, and that, looking beyond what you're going through right now, it can just a whole new life can be blooming for you. So I just loved that you said that. So please, hello.
That's
And
absolutely true. Hello, hi, Donna, hi, Kevin. Yeah, it
yeah,
was a nice hangout in the green room before hopping
yeah,
on the
there
show
you
here.
go.
That was great. I appreciate
So
it. And yes, I absolutely believe that no matter where you are, listen. There are two kinds of people who are listening to this show: people who are themselves struggling currently with a substance use disorder, or people who know someone who is. It's so widespread. It's so universal. There are at least 20 million people who probably could check into a treatment center, 20 million people in America today, and probably another 50 million who you wouldn't kick them out if they showed up. They have either binge drinking or some other maladaptive relationship to substances. So extremely common. If it's not you, it's a neighbor or a relative or a coworker. It's someone close to you. So as far as can you have a life after that, is life over? And it's quite common to think, oh no, this is I'll never have fun again, or I'll be so embarrassed I can't be seen in public or look anyone in the eye. None of that's true. I'm Exhibit A. So 25 years ago, and how I got into this area of medicine. 25 years ago, I went through my own experience, discovered me of all people had substance use disorder. Now it might have been obvious to a couple of other people because my substance was fentanyl, which I used to have to repeat a couple of times because no one had ever heard of it. But now, of course, unfortunately, everyone.
Yeah.
And it's because I was working in an operating room, and I was close to this stuff, and got curious one day because I didn't like how I felt. And it's kind of like putting just your sleeve into the machine. It'll pull you in. There is no passing fancy or experimentation. It'll really get a hold of you, and it did me. And fortunately, I was in an environment, and we chatted about this a minute also, where I had support. I had people who were very interested in me getting through this. And what that looked like was participating in a program that lasted a very long time. It was over 5 years after completing treatment, after being sober, after going back to work, after going back to work in the operating room, all of that stuff. They still kept an eye on me for a long time, and with good reason, because being a physician, especially being an anesthesiologist, is a position of public trust. And so many people had vested interest in me staying sober. But I've been out of that program now for over 20 years, and something stuck, right? Something changed because I haven't gone back, and I live a truly magical life. I mean, not that there aren't problems, there's ups and downs, of course, but not waking up every morning with the dread and the sweating and the feeling like if I could just tell somebody, but I can't tell anybody what's going on with me. I don't have that feeling anymore.
Yeah.
And I don't have it because the habits that I picked up along the way of getting well have stayed with me. And so many people think of addiction as like a broken bone. It's something that you happens to you, and then you heal it, and then you go on. But that's not really how it is. It's more like learning. It's more like learning. It's the same process. Same process as learning. And unfortunately, when you learn to manage your feelings with chemicals, you don't forget how to do that. So even if it's been a very long time, that pathway, like riding a bicycle, is still there. And so that's why we say it's contingent on the daily practice. And it's not the same as in the beginning of hanging on and hoping and white knuckling and sometimes less than one day at a time, an hour at a time, just to get through. It's not like that anymore. That hasn't been that way for a very long time, but it it's still something that you have to pay attention to.
Mhm.
And in that way, it's a weird illness. We call it a disease because we don't have another way to describe it. It's like you learned a bad habit, is what we used to say, but it seems much more severe than a habit. But at base, managing your feelings with chemicals is a habit as much as it's anything else.
Yeah. Wow. So you had mentioned that it took you a good 5 years, like if you had to really put a timeline around this, and or that you were in um, receiving help, if you will, for a good
Support, help,
5 years.
yeah, of course.
So
Accountability, sure.
yeah. So tell me how that's different, or the program you went through was different than, say, here's somebody on just general health insurance, not a doctor, not a healthcare provider, and they, you know, have to try to go to a center if they have to, maybe not get paid because they've lost their job or different things like that. And then
Sure.
or maybe they still have health insurance because they're part of a family insurance or something like that. How is that different from what you experienced to what maybe millions of others who aren't in the healthcare industry? How does the actual rehabilitation look? Is it 5 years? Is it 5 days? 5 weeks?
Well, let me emphasize that even though I was in the program for 5 years, maybe I didn't need to be. Maybe 3 years would have been fine, or 2, or 6 months. I don't know. I know that 5 years turned out to be, so far, plenty. That was an adequate amount. And I will say that all that is, so it's not like I was sitting in a treatment center for 5 years.
Right.
That only happened for a few weeks. It's that the habit of showing up, staying abstinent, um, participating in some sort of mutual help group where we can talk honestly about our feelings, listen to one another, pursuing the spiritual aspects of life, understanding that there's more to life than what we see. I think these are all major ingredients in a sustainable recovery. Also, eating well, sleeping, exercise, pursuits outside of work, all those things combined added up to a nexus of a different life. So I've lived a different life for many years before leaving the program.
Yeah.
I think if I can shed a bit of light on the way treatment is structured, I'm actually writing a book on this topic that you're talking about. So the way traditional treatment is structured, most people are not interested in it, or unable to participate in it. So of the huge number of people that I mentioned at the top of the conversation, millions, right, tens of millions of people who should get help, it's only somewhere around 5 or 6% who do. And by that I mean check into a treatment center or an outpatient program, or get some counseling, or see an addiction doctor, or any kind of help at all. It's around 1 in 20 people who absolutely should come in and get a different plan, get medically evaluated, get on a different program. Only about 1 in 20 does. And our approach to that has been to talk about stigma, which is true. Of course, it's stigmatizing to have any kind of mental illness or substance use disorder, and to say that if only we didn't have stigma, then there'd be a flood tide of people bursting into treatment to get help. But I don't think that's true. We've watched in the last 10 years for sure, maybe 20, the destigmatization of the problem. The fact that I'm on your show, we're talking about this, is something that it just wasn't happening 25 years ago when I first came in.
Yeah.
So I think we have to be more rigorous and more critical of ourselves as an industry, and maybe as a society, about why people don't check into treatment, why they don't even get a chance. Forget 5 years, 5 minutes, or 5 hours. They don't seek this kind of help. I think it's a number of reasons. I think it's expensive. You alluded to that with the insurance costs, right? It's very expensive. But it's expensive in non-monetary ways as well. So time away. The paradigm is set up where you got to go away, at least for certain portions of the day as well. The concepts that are tossed around, like hit bottom and live or die and hopeless, doesn't characterize most of the people. Most people are managing, they're quietly suffering, and they get by with scrapes day to day. And you're like, hey, you have to go away for, set 5 years aside. That's a special program for doctors and nurses and pilots and things. But just the regular treatment, let's say you go away for 30 days. Take a poll from your listeners and ask how many of them could easily drop out of their lives, not just work, drop out of their lives for 30 days. Very difficult, right? Very difficult. Add to it the disruption in work, right? So you're missing work. Add to it the stigma that comes from getting help. That's the irony, right? It's not just the stigma of having the problem. It's a stigma of going to get help. Other people counting on you, etc. So there are many reasons. Some say, listen, I love Alcoholics Anonymous. I think it's great, but some say that it's the promotion of this religious appearing or Christian organization, and people don't want that. They want something else. There are many off ramps to the road to treatment. So there are innovative approaches. We could talk about some of those. That's some of what you mentioned earlier. But I think how we regard the problem is part of it. How we regard the solution is another part of it. So for me, it's you know, no more fentanyl, the abstinent lifestyle. But not everyone is that the right choice for. Not everyone needs to be 100% abstinent, and that's kind of heretical in most recovery circles. But if you've been to the last couple of American Society of Addiction Medicine meetings, they're talking about what they call harm reduction. And that used to be clean needles and syringes and HIV testing and condoms and so forth. But another way to look at harm reduction is meeting people where they are. Not everyone is ready to pursue this life all at once. So in any case, if you broaden the definition and if we start to get creative and innovative about what help means, maybe it's not from I mean, we're all three professionals here, but maybe it's from a peer counselor, or maybe it's from clergy, or maybe it's from lay clergy, right? You start to broaden because really what matters, you have to know a little bit. You have to know just a couple of things, like, don't switch to beer if you've got a wine problem. You have to know a couple of basics. But beyond that, it's mostly about human connection. It's mostly about connecting and being present in the moment. Most of us find that there's plenty there, right? We don't need to run and get away from the feeling of being around someone or being close to someone, being honest with someone. So that's really what it all is. It's about changing your story. It's about changing the story you tell yourself. I'm no good. I don't fit. I don't belong. I'm not smart enough. I'm not handsome enough. I'm not rich enough. I'm not tall enough. I'm not enough, not enough. Or I'm too much, right? I'm too much. I scare everyone away. No one wants to be around, etc.
Yeah.
None of that's true. None of that's true. Without getting too religious, I don't think God makes mistakes. So although I used to think differently. So if you're here, you're here for a reason. And if you accept that, then your responsibility is to be as much in service as you can to your fellow man. And that gratitude plus service, I think, is incompatible with drinking yourself to death or managing your feelings with chemicals.
Yeah.
You mentioned a framing that I really like when you're talking about a learning or relearning component of how to deal with feelings. You mentioned several times there. The one curiosity I have is when you're talking about the different on ramps toward addiction, we talked about individual feelings. I'm sure you've encountered a number of patients you've worked with or folks that you've known over the years that maybe feelings isn't part of the equation, overall. Maybe they're trying to say, I've got pain in particular, some kind of bodily pain that I'm trying to do that particular pain in order to function in life. Or as you're mentioning, maybe there's other feelings, related to I made a mistake or something went wrong. It was an acute issue that happened. And then they decided that acute issue required some kind of intervention, which happened to be an addiction process that ended up going into play. You also kind of mentioned pre-show some of the issues when it comes to just dabbling in things and thinking there's some experimentation, right, overall, or exploratory processes that then lead individuals into an addictive pathway. My question really is along these lines, regardless of how someone enters into this kind of learning process of thinking what I need to do is take another drink, another pill, another whatever the case is for me to be able to function and move forward with, how does that mindset change? Where does that epiphany moment happen for a lot of individuals? You said it's not a rock bottom. It's not a, X, Y, and Z. It's a reframing and relearning, the process. How does that end up occurring, for those individuals? I know I asked you a very simple question. So,
well, separating the two. So people who have legitimate pain concerns and who are on pain medicine, let's make it, narcotic pain medication for a chronic pain condition. Stephen Pasek gave me the best rubric I've ever heard. That's back when I was doing my pain fellowship, which is you look at the person's function. So if somebody is on pain medicine and their life improves, in other words, what they're able to do increases, then it's probably reasonable, it's probably legitimate to be on that pain medication. Doesn't mean you're off scot-free. And people who have a substance use disorder, you still have to pay attention, history of it. But if a patient says, Yeah, I take a couple of Vicodin, and I'm able to get through, a whole episode of Below Decks. Then um, that you'd have to compare that with somebody who says, yeah, I take a Vicodin, and that lets me get dressed so that I can go to work and do my job.
Yeah.
And so I think you have to be honest, and that's really the fundamental answer to both these questions, is the patient has to be honest with himself about whether or not the drug is doing more for him or to him. Now, you can have both. It's not always clear cut. It's not always, well, I take the pill and it's only 100% all good. But that's not true with anything. There are always side effects.
Yeah.
And I think it's impossible to separate out feeling from pain relief, because pain is pain perceived. We knock people out in the OR and do unspeakable things to them with scalpels and bone saws and so forth, and they don't feel it because they're not aware. They're unconscious. So if you're awake and taking pain medicine, it's working on your sense of suffering and hopelessness of being trapped as much as it is working on pain receptors. So separating the pain group out, I think you just have to be honest about whether the medicine's helping or hurting. And if both, get help for both. If it's helping and hurting, then you need to do some substance use management or some training or some teaching or a program. And if it's helping, then probably stay on it. There's this one tiny little group, which is, well, it's probably not that tiny, which is something we call pseudo addiction, which means the patient keeps asking for more, but it's not because he's an addict. It's because you haven't given him enough yet, because it still hurts. It still hurts. We're like, hey, that should be enough. You're like, well, different people have different pain tolerances. Different people have different medication responses. Some people can't metabolize codeine, for example, about 1 in 6. So you're like, why isn't this working? I'm giving him a double dose, and it's not. Well, at least you found one of the 1 in 6 that codeine doesn't touch. And also there's tolerance. So sometimes medication that used to work doesn't. It doesn't mean that it's being misused. It could be that you're just not giving enough. Now, that's not licensed to just hand the med jar over. You have to be very, very careful with that. But do ask yourself, if, just because the patient's asking for more doesn't mean you found an abuse situation necessarily. Okay, back to the first part, which is when do you know, right? When do you go from I'm having a glass of wine to the glass of wine is having me?
Yeah.
You know. I'll just say it plainly. You know, right? And have a conversation with yourself at 2 a.m. in the bathroom mirror, and So I don't think there is such a thing as denial. I think that's a ridiculous notion, right? That you're somehow able to fool yourself in the middle of alcoholic spiral that this is only social, right? People know. That's one of the good things about the stigma erasure is that your friend, the scared look on your spouse's face and that look you've got right there, Kevin, will probably, right? Like, oh no, I'm fine. Other people probably know as well, but this is an illness that lives in secret. And so you're probably the best person to ask if you're suffering through this, and
Yeah.
A friend of mine named Cameron Harold is a famous executive, and it was a different context, but I'm going to steal his line here and credit him, but for a different context. He said, when you have a doubt, you have no doubt, right? So when you're thinking, do I have a problem? You have a problem. Now, if you want to test out whether or not you have a problem, stop. Paradoxically, people with problems, they say, I'm going to prove I don't have a problem by drinking. That will prove that I don't have a problem. But the way to prove that to yourself anyway, that you don't have a problem is to stop. Try not drinking for a year and see how that goes. And this is because although the presentation is alcoholism or alcohol dependency or drinking too much and the consequences on the body of that, the real problem is not the alcohol, it's the reason you were drinking in the first place. So if your problem is the alcohol, then when you stop, everything will get better. If your problem is something else, which is the substance use disorder, which is not about the substance, then your problems will get worse when you stop drinking. You'll hate yourself more, you'll hate your life more, you'll feel more remorseful and more embarrassed and more sad and more angry and more confused when you stop, because the medication, although it's turned and has a side effect, you guys are experts in side effects, it it's also treating the feelings. And so when it goes away, treating the self-perception, treating the story that you tell yourself. So when it goes away, you're left with you plus the withdrawal, plus the damage that you did. So your life gets worse when you stop initially. That's another way you can tell.
Here's an interesting one for you, since you brought up the side effect component, and that's fantastic. I love and the way you've reframed the learning components of kind of letting yourself go. The question really you should be asking yourself is, what if I stopped? Does it actually change the way that I'm living my life? So here's my question back is, we had about, oh goodness, Donna, now it's almost 15 years ago, but let's say 10 years ago, actually, Tylenol went from being an extremely prescribed medication with absolutely no cap that everybody could throw every bit of Tylenol at a patient. And then we realized, you know what it does? It actually hurts our livers. And people are using it in quantities we had no idea they were using it in. But guess what? Everybody
10
was
grams a day.
they're gravitating toward it. Why? Because it was easy, right? They had pain. They grabbed something. They increased the dose of it to try to be able to chase that pain and to avoid it overall. In society, we have created a very likely loop towards something that we don't regulate like a drug when it comes to alcohol, that we have the ability for us to go into a liquor store, grocery store, whatever the case is, and grab something to be able to take care of whatever we have going on. We have a self-diagnosis and we have a treatment that we can utilize right there. How do we create, and nothing but easy questions for you. How do we create something that is better than that option? How do we make an option in place that someone doesn't go, you know what, I've got this problem. There's a solution on this aisle in the grocery store that I'm going to put into my box. How do we reframe the American mindset that we go, nope, this is the first option I'm going to go with and move toward?
For alcohol use disorder?
We can use anything. Let's say that instead of going to the grocery store, we say I'm in this pain, or I've got this feeling going on. I go to my practitioner and I say, prescribe me this. And now you're on an opiate, or now you're going into a street drug, or whatever the case may be. That's the initial thought. Self-diagnose, and then be able to find the solution for you to be able to take, which leads to addiction. How do we, two things. One, what is that? Like, what is the alternative that we should be thinking about instead of that substance?
Sure.
And two, how do we get the mindset to shift there?
So, well, that's very interesting. I mean, that's like the problem of all time, is the timely intervention, right? So there's an old Warner Brothers cartoon called Sylvester and Tweety Bird. I suspect you guys know it. And there's one of my favorite episodes. It's from 1942. So that's 7 years after the founding of AA. So that's how quickly AA grew. It had a Sylvester and Tweety Bird cartoon, which was based on Sylvester's inability to leave alone these small birds that he kept wanting to eat. So he clearly has a problem, and eventually, with this mad obsession, and of course, Tweety keeps escaping. Right, that's what Tweety does every single time. Always figures out a way to keep from being eaten. In desperation, because he realizes that there aren't enough birds for him to eat. He can never eat enough birds. That's the epiphany, right? No matter how much I drink, it's never going to be okay. So he signs up with a self-help group called BA, which is Birds Anonymous. Have you seen this episode? This particular cartoon? So he gets a sponsor, and because he's in a moment of desperation, he's trying to change his life, and he signs up for this program, and he gets a sponsor, and the sponsor hangs out with him in the rest of the cartoon. And of course, Sylvester is unrepentant, and he sooner than later goes after Tweety again. And there's this classic scene when he's got the bird and he's dangling him over his mouth, and he's just savoring this moment right before he swallows Tweety, and he opens his mouth as wide as can be when a toilet plunger comes and sticks to his mouth because his sponsor has fired it from a bow like an arrow, but it's gummed up his mouth and covered him, and he's trying to get it off of his face. Anyhow, so that's what, almost 80 years, or 80 years ago, right? 83 years ago, this
Wow.
cartoon came out. So back then, they were trying to figure out what's the key moment. Now, that's the key moment right before you swallow the bird. If you could make an intervention. We've been
Mhm.
trying to figure that out ever since.
Yeah.
So if you follow gambling or any kind of confidence games, there's the tell. So we telegraph what we're doing before we do it. There are signs we give off even before going back to drinking. The whole point of it is just to catch this before it turns into a problem, right? So before you grab the Ernest and Julio off the shelf, before you go to the doctor and make up a story about your anxiety, or maybe you tell the story of your anxiety but seeking a pill.
Mm-hmm.
Before doing all that, what's the timely intervention? And there's all sorts of different approaches, right? So law enforcement tries to get rid of all the drugs, so you just have to wait until your feeling for them goes away because they're not available. I don't need to tell you how well that's going. It's not going very well, right? We educate the doctors and we say don't prescribe pain medicine because of oxycodone and so forth. This is upsetting to many, but it has not been true for at least 15 years that people who develop a substance use disorder with opiates get their first opiate from the doctor. That's not been true since certainly 2010 and maybe 2008. So the idea that the OxyContin scourge led to everybody using fentanyl was maybe true in 2005 and 6 and 7 and maybe 8, but hasn't been for a long time because doctors tightened up their prescribing practices and maybe over tightened them in case of some people with chronic pain.
Mhm.
So how do we make that intervention to keep people from being curious about taking a pill at the moment when they want to be part of a group or part of a social thing, or they're feeling stressed about school because it's mostly a young person's problem?
Yeah.
I think the answer is doing shows like this. I think the answer is to raise the conversation. So it's tying it back into myself when my department chairman said, "Hey, we think there's the problem, and we think you need help." Part of why he was aware of that, I believe, is that only a couple of years before, another senior resident in the anesthesia department had overdosed on fentanyl and was found dead in the call room.
Mm-hmm.
And tragic, right? Tragic. Yeah, young man, just like me, just like me. But because of that, I think my chairman was aware. I think he was paying
Right.
attention. I think he
Yeah.
was putting two and two together a lot earlier, certainly than maybe if there were signs before. But it was on the differential diagnosis, we would say, right? It was on the list of possibilities. Maybe this hotshot resident may have a problem, right? He's looking
Mm.
skinny, he's looking shiny, his work product is outstanding. He shows up all the time for cases. He does not seem to be intoxicated, but that's because I wouldn't use till after work. So I'm in withdrawal all day long then. And so he had enough clues to say something before tragedy befell me.
Mm.
So that's why I say shows like this, where we're talking about it, where we're being honest about it, where, we can do our best not to be embarrassed about the details and the stupid things we do behind these drives to not get caught or to keep it going or figure it out. If 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 that's part of the conversation, I think there's a much better choice, right? So if it's like grab some Jack Daniels, not to pick on Jack Daniels, or tell your friend, man, this has been a week. Do you have a minute for me to tell you about it?
Mhm.
Right? That's how to get well. That is the move that when you do that, Jack Daniels is the farthest thing away from your life because you've got a connection with a person. You realize that you're not alone, and maybe something you say might help him,
Yeah.
right? And so feeling like you've got no traction and you're no good and life is just slipping by, and something you say, even if all you're doing is giving him a chance to help you, don't cheat him out of a chance to help you. I'm piling a lot on this fella,
Right.
but so that's the answer to the question, is
Mm.
to make it so everyone knows that you don't have to get drunk when you're feeling blue or celebrating. You don't have
Mhm.
to.
Right.
It's not required.
I would love to know a little bit more about the VHAB app and then some of the steps that you offer or that you share with patients who are needing assistance with the addiction. So I know as we've talked about it, there's many different programs. And I think a lot of people are familiar with with the 12 steps, right? Um, so, but what is it that that this VHAB app can do for people? I'm assuming more accessible too. We talked about some of those barriers, right? But also, what are the steps that you think are just, really important to get on track?
Sure, that's a great question. So the thing the thing we're working on is the what happens after you get out of treatment. So we have this for back to the broken bone. If you break your ankle, heaven forbid, but you go to the bone doctor who puts it in a cast, maybe surgery, maybe you need something temporary, but usually the surgical piece comes out. And if it's just a cast, which is my favorite example, that goes on for 6 weeks, or a walking boot until the bone is healed. You would not leave the walking boot on for the rest of your life. And so being sober and stable in recovery in a treatment center is like being in the cast. It's only supposed to be there temporarily. Life is supposed to get better. Your ankle's supposed to get better to the point where you can bear weight on it. Now, you may need physical therapy, right? You may have gotten stiff and it may have gotten atrophied, and you may need to get stronger anyway. And maybe something you did about your balance or your weight or your core strength or your back, or who knows, your fitness overall may need to be tuned up so that you don't break your ankle again. So we're good at all these things. We're good at physical therapy. We're good at plyometrics. We're good at gymnasiums are everywhere. Most people have, some passing acquaintance with a gym.
Mhm.
So there's that particular problem. We have all sorts of aftercare built up for, right? You can get into a running club or a cycling club so you can keep it limber and get it strong again. There's special footwear. There's all kinds of aftercare for a broken ankle. For substance use disorder, people usually want to get in, get out as quickly as possible. So the concept behind VHAB is, how can we help people stay connected to a recovery program? And I'll tell you what the key steps are, key ingredients. How can we keep them connected for the long term? We know that from the kind of program that I went through, that if you stay with it until completion, your chances of staying sober are about 9 out of 10 or 19 out of 20. So it's 90 or 95%. Contrast that with treatment centers, which have somewhere around 10%, maybe 14%, maybe, but it's hard to get to see the data. So treatment centers, back to the broken ankle, would be like just putting the cast on and saying, well, good luck. So it's going to be stiff. You're going to be wobbly on it. Chances are it's going to get re-injured. What we're bad at is aftercare. We're bad at longitudinal care. This problem, if you remember, takes a while to appear. It's not like you have 10 beers that first night and then check into a rehab in the morning. It's more like a slow accumulation, right? Fun with problems, and then just problems. And so it's in that last stage there. That's when people check into a treatment center. But you've had years typically of managing your feelings with chemicals, and it takes a long time to build up a new habit system. It's not built up in 30 days. And so the concept there is that we stay with you after you leave so that you can remain connected. And connected to what? So connected to community,
Mhm.
education, and accountability. Community is pretty obvious. We've been spending a lot of time talking about that. It's people who get you and are there just to support you in your recovery journey and vice versa. Education, some of the stuff we've talked about here, right? Knowing how to get through tough situations, what to do at Thanksgiving with your crazy family, how to deal with, I don't know with the depth of the Native American piece, but it's not that easy on the reservations to stay sober in many cases, right? It's cultural. So how do we help armor people for tough situations, right? How do we help them elegantly evade social pressure and peer pressure to keep drinking or keep using? That sort of thing. But also how your body works, how to get sleep, how to get well, how to take care of yourself, what to tell people, how to feel about this, how to help others, so that you've got a mission component. So there's a lot of education. And then the last piece is accountability, because as Voltaire said, I have tremendous willpower in the morning, but it's gone by afternoon. So how do we stay on track? And this is back to the Sylvester and Tweety bird, right? So how do we notice when we're beginning to slip, when we're beginning to drift? The last stage is uncontrolled use. Right before that's controlled use. Right before that is belief that the substances are good for me. And right before that is denial of the past trauma and pain. And so there's breadcrumbs along this trail, and they're repeatable. So the trick is to get a little nudge or a little red flag or a little reminder, or maybe your peers notice or something to let you refocus and notice that maybe your shirt tail's untucked, so to speak. So community accountability and education are the three components, and staying with people for the long term. That's the whole idea.
Yeah. So I think this really ties into what I had read, is the three pillars of this habit change too, right? So it doesn't really matter what the addiction is. I'm assuming there's three pillars for habit change. And I believe it was on the information on VHAB. If I didn't break that down in my notes,
I
that's where I
believe
started.
you have to tell me what they are. I don't know.
So know what to do.
I'm not sure what the three pillars are.
Yeah. So one is know what to do, have a
Uh-huh.
group support you, track your own progress. And it
Yeah, there
seems
you go.
like that is
Yeah.
pretty much what it is. But how does somebody know what to do? How do they know? Is it that, oh, I know I need to stop this, or
No,
I
that's
know
how
I
you,
need
that's
to
before
reduce?
you get in. Yeah.
Yeah.
What to do next? Yeah. Well, you need somebody to show you the ropes.
Yeah.
You need Ed showing Sylvester not to eat the birds, right?
Yeah.
Here's what
Yeah.
I did. Interestingly, a lot of that
Got it.
comes just from sharing your own story.
Yeah.
But here's what I did. Here's how I got through this. Here's how I got through the bachelor party. Here's how I got through the trip through Rome without drinking. Here's how whatever. And whatever this particular situation is. The nice thing
Yeah.
about large groups is chances are someone has had that experience. Someone
Mhm.
has or close. Someone's been through that. So
Yeah.
yeah, it's being willing to learn, and it's asking for help. That's how you do
Mhm.
it. It's astonishing how much help people leave on the table just not asking for it. We don't. I don't know.
Yeah.
I do know a little bit about it. We
Yeah.
think that they don't feel worthy, or that they don't want to bother somebody or take their time. But remember, you're cheating your friends out of a chance to help you. Don't you like helping your friends?
Yeah. Totally.
Don't you like
100%.
don't you like helping strangers just
Yeah.
because it feels good to do that? So
Yeah.
don't cheat somebody out of a chance to be helpful.
Right.
Ask
Right.
ask for help. You're worth saving, is what I'm trying to say.
Yeah.
I love that cyclical blessing thought process there. I think there's a lot to that. I think biblically and societally. The thing that I'd love to know a little bit more about when it comes to asking for help. You know who else is really bad at asking for help? Clinicians, really bad at asking for
Oh
help.
yeah, we're terrible.
They,
Yeah.
they get drowned in all the monotony of having to go through their files, their cases, their 7-minute appointments, trying to get to the next individual. And when they encounter someone with substance use disorder, it becomes a major conundrum. How do I add this person to my caseload in general?
A
How do I?
quagmire. Yes, they're in the bog. Yes. Well, they don't know
So
what to say. Yeah.
yeah, they don't know what to say, and they don't know what to do either for the next steps. In
Yeah.
general, how
That's
can we help our colleagues to be able to be more successful in substance use disorder and helping those patients?
yeah, that's an excellent question. And yeah, for the ones that recognize that it is an actual problem, and let's say you're running a primary care office, and the classic one is my wife thinks I drink too much, right?
Yeah.
My wife thinks I drink too much. By the way, there's a study that just came out that if someone comes into a doctor's office and says, I think I'm okay, but my wife wanted me to come in terms of, because she says, because I've been complaining about this symptom or I've got this feeling or something. So here's what the chief complaint is. That has a 100% positive predictive value for something serious. 100%. So if someone comes in and says, well, I wouldn't come in, but my wife wants me to be here, get out the electron microscope because there's something seriously wrong. Yeah, exactly. Clinicians don't know what to do. So, right, guy says, my wife thinks I drink too much. Well, what does that mean? Listen, we spent most of an hour talking about a topic that's very difficult to pin down. Takes a long time to understand. Does that mean too much this weekend, or too much when her parents visit, or too much at the lake house, or too much for years? And what does that mean? Is it timing? And so what do you tell the guy? Do you say, well, cut back, or you need to go to a 60-day inpatient program, or you should talk to your rabbi, or you should talk to your friends. It's just very difficult in the, like you say, 7-minute visits to know what to say next. Alcoholics Anonymous has a 20-question self-assessment, and you could hand them that, and it's all the classics. So it's all the things that are found in the DSM-4 now, which is, continue to drink despite adverse consequences, drinking more drinks than you used to, find it difficult to not drink even though you planned, drinking before events. So there's a bunch of things in order to make the diagnosis, because as I've said, it doesn't matter if there's a room full of addiction doctors telling you, Kevin, this is a problem, right? We just go around the circle all telling you. It matters what you think. If you could just wave us all off and go, oh, well, no, these old eggheads, they don't know what they're talking about. So it's a question of getting the patient on his own team by appreciating the seriousness of the problem. And then there are tests that you can do. And I don't mean blood tests to see how bad the carbohydrate deficient transferrin is. I mean, there are tests like stop drinking. Now, you don't want to just stop if you're seriously alcohol dependent, because that's dangerous. But that'll come out in the dose. So how many drinks are you drinking? And then even that question is fraught, because people who drink minimize, but not everyone who drinks minimizes. Young people exaggerate their drinking. Old people minimize. So you get a 35-year-old, is that old or young in the right? So it's tricky. And so I do have an idea, which is to provide an education system, and now you can maybe do it with advances in AI, so that the clinicians can have a little suggestion for what to do next, like type it all in, or ambient scribe listening, and it's like, there's a 42% chance that there's an alcohol use disorder here, right? And then you can move those sliders up or down by the next questions. Here's to recommend. Maybe you get a CBC and look at the size of the red blood cells, right, to give you some idea. Maybe you get liver enzymes and see what's going on, or palpate the liver. So we keep picking on alcohol, but this works for all the substances. There are triggers. So I think awareness is the most important part, and I think having a rubric, right? So part of why we treat blood pressure so well in this country is we have a great rubric. Get the blood pressure, give the medicine. If there's no side effects and blood pressure comes down, it's good. If one of the other two things happens, we give a different medicine or manage the side effects or add another medicine. So we have a great flow chart for how to handle blood pressure. We don't have a great flow chart for, my wife says I'm drinking too much, even though now we know that's 100% likelihood that he's drinking too much.
Oh, I think that's really helpful, especially the algorithmic component. And like you're saying, our episode is flying by. So I only have one last one for you, Jason, is this. So when I work in like the machine learning and AI space, we do a lot of things with biomarkers, in general that are kind of popping up on what can we do to be able to firsthand, as you were saying, there's some level of awareness, especially for the individual. And sometimes if we have a sleeping problem, there's a wearable we can put on and we can tell, hey, I'm only getting X number of hours per night of sleep. Or if we think we have a problem with exercise tolerance in general. We can look at what our heart rate is doing while we're exercising and have some kind of assessment
Sure.
of
Sure.
what
Variability, MOU. Sure. Yep.
you got it. And so with that being the case right now, if there's someone that thinks, I don't know if I have a problem or not, they're in that phase, right? That kind of discovery phase. What either pieces of technology or questions, you already mentioned one with kind of the AA self-assessment. What would you recommend for them to utilize? And I think this can apply to both clinicians and patients when we're doing that awareness. What would you recommend for them to do to go beyond the discovery phase and truly give themselves or their patients an answer?
Well, the oldest recommendation is behavioral, so it's to try some controlled drinking, right? Try to have one and then stop. And if you find that you can't, then you've probably made the diagnosis. The flip side of that is to just try and stop and see how long you go. And if you're going to do a dry June, I just made that up, and you get to June 4th, then you probably have your answer. And especially if you're like, oh, well, it's just a wine spritzer. I mean, we're out here for the garden party, and you have a story about what is maybe a life damaging or life shortening problem, and the story you're telling yourself is, oh, well, a friend came over with a 6-pack of beer, so it must be okay.
Mhm.
Then those are two behavioral signs that you may give you your answer. Very interesting question. So we're looking at a couple of things. We're looking at sleep disturbance. So alcohol is hell on sleep. It just trashes your REM and non-REM sleep.
Yep.
So if you're tired all the time, and if you're having a drink before bed, those two things may go together. And so you'll see that in your Oura Ring or your Apple Watch or your whatever other sleep monitor you're using. You'll see that your total REM time is less than an hour overnight, and your non-REM time is also less than an hour. So you're basically just destroying your delta level sleep. You're not sleeping at all. So that's a biomarker sort of a thing. Heart rate variability plummets when you're drinking alcohol, so you get this very non-variable, even to the point of decreases in respiratory variation in heart rate. Yeah, just flat and tachycardic typically. The number one cause of atrial fibrillation is alcohol. So if you have AFib and you're drinking, that's an irregular pulse. You check your pulse and it's not even beating regular, it's beating every so often and then a couple beats and long pause and so forth. That's AFib. That's a late finding for alcohol use disorder. So you can check that in your heart rate or your if you've got some sort of Apple Watch or something that will check your pulse, or one of these cardio mobile things that'll do it. Like, well, you have AFib. So so those are a couple of biometric things or things that you can look at, and then the standard blood panel will reveal a lot of things as well. So if you're taking on water in that respect, you've got elevated liver enzymes, you've got big red blood cells because alcohol is toxic to bone marrow, and so the cells are having a hard time recovering, and they get big and boggy and larger size, the RBCs. Iron deficiency, CDT we talked about a minute ago, GGT elevations, things like that you can see on standard lab panel. And then there's probably some other things. There's probably sentiment analysis in the way that you communicate, because we get short-tempered and edgy and irritable in the hangover phase. You could probably look at your credit card receipts and see where you're spending money. That's probably a tell on where you're going. Probably your GPS, where you're going. There's been some geofencing apps that try and say, well, some of them are obvious, like Kevin goes to this bar, so if he goes to this bar, he's probably going there to drink. So some of them are a little on the nose, but we have other habits and things that are, as I said, tells. And maybe we can hear something in the voice. It's possible that a voice print analysis might be one of the best tells of all.
I love it. That's super helpful for folks to be able to have that in the back pocket to be able to utilize some of those. So thank you so much for that, Jason. Any last questions, Donna, for Jason?
I have so many, but I know that we are well beyond, and I definitely have more to ask. So I'm hoping that we get to have you back.
Of course.
But I just, we had talked about this beforehand. If you could just wrap up for us as to what is most important for patients that might be listening, caregivers, and then providers, like what do you want to make certain that they leave this episode with?
That's great. The most important message is one of hope. So it sounds silly and maybe like I'm crazy, but if you're diagnosed with a substance use disorder, that's great news. That's really good news because you're not crazy. You've developed this maladaptive pattern of relying on chemicals to change the way you feel. And what's good about it is that at least you now know what the problem is, and we have fantastic treatment for it. So no one needs to continue in that space. We have approaches that are better than just about curing any other problem. Now, when I say cure, it doesn't mean that you can continue to drink the way you've been and it not affect you. It means that you won't need and you'll choose not to rely on substances to manage your feelings. So it's actually a great day if you figure out that you've got this problem, because millions of people have had it before you, and nearly all of us are doing great. So tremendous hope, a broad road. It's not you're only going to have to give up your misery, which we could refund if you want, but you're not going to want to go back to that life. And for the caregivers and the loved ones, it's another message of hope. So you didn't do this to the person if you're one of the loved ones or family members. That's the good news. The bad news is you can't fix them. So you can't fix the person. There's a lot of sad shipwrecked people trying to do the impossible, which is live someone else's life.
Yeah.
So Mel Robbins has a book out right now called Let Them.
Mm-hmm.
And I think that's a terrific message, which is people need the dignity of their own journey. Doesn't mean that you shouldn't tell them how you feel and what you're experiencing when you observe them on this particular path, but you can't live their lives for them. Yeah. And for the clinicians and the pharmacists and doctors and so forth who are looking at a funny script coming across, or who are patients back in my office, or who pretty clearly smells of alcohol, let's say, but denies drinking, all the stuff that we see all the time. Gentle confrontation, but with support, right? Support and above all, compassion, because we all have feet of clay. Everyone is a human being. Everyone falls short of the highest glory. And so if you approach people that way, rather than be angry with them for their foibles, you'll catch a lot more with honey than you will with vinegar. So I would say message of hope for all three, and educate yourself. Learn if you want to read my book called Outsmart, right? Yes. Outsmart Your Addiction, which is about using the part of your brain that works, or the new book I've got coming out called Take Responsibility. But there's a lot of sources out, a lot of ways you can become an expert in this for yourself, and help a lot of people. That's what I hope happens.
That's great.
I love that.
And just one more time, I just want to repeat the books. The first one is Outsmart, and then you said that the next one is coming out, Take Responsibility. And when is it going to be out?
It'll be out at the end of the summer.
Oh, wonderful. Awesome. Congratulations on that.
Perfect. Please go and look at those books, folks. I think that there's just a ton of knowledge wrapped into one human being, which is fantastic and a real blessing to the rest of us. So glad that the addiction component is something that you're able to kind of share that hope message. Really appreciate that on the show today. One thing I will show, one element of hope, is through somebody that makes this show possible, and that's through Remedy Chain and them providing medications for individuals that need it and can't afford it. I'll play that and I'll sign us off. But thank you all for joining us today. We hope to see you on the next episode of The Med List.
At Remedy Chain, we know throwing away perfectly good medicine feels doubly wasteful. It's bad for the environment, and it could have been used to help a fellow human in need. So we found a remedy. Now you can donate your unused meds. Our pharmacists inspect and certify every donation so it can be safely and legally redistributed to vulnerable patients. Visit donatemymeds.org and click the Donate Meds button. Unopened, unexpired medication in original packaging is eligible for donation. Open bottles, controlled substances, and temperature-controlled meds are not eligible for donation. Once confirmed, we'll send a donation form to sign and prepaid shipping instructions. And we'll let you know once we've matched your donation with a patient in need. Together, we complete the chain. Remedy Chain. Visit donatemymeds.org today.